See, multi-drug resistance in burn patient is a very common problem. And we at a educational institution, a research institution at Department of Pharmaceutical Sciences and Drug Research, Punjabi University, Patiala, what do we do over here? We started developing formulations for burn wound using silver nanoparticles. And we found that this area is a big one. I have edited a book on this multi-drug resistance, and we work as a team. We have Dr. Abhishek on board from Wolverhampton University. He's a regular visitor to our lab to train our students. And my colleagues, Dr. Dhandeep Singh, Dr. Nirmal, they have expertise in chemistry, and Dr. Nirmal expertise in pharmacology, and myself expertise in formulation development. But to develop a formulation, we have to understand that when you require, what sort of formulation do you require at various stages of burn wound. To start with statistics of burn wound, it has been found that there are many people who 25,000 people are affected in each continent with burn wound, and many are hospitalized. And it is very sorry to say that in spite of such an infrastructure, there are 12,000 deaths per year. The death is not because of the burn. The death is because of infection after burn. The care of the patient after burn. You have to have an immediate care of the patient. Whether with a formulation, you have to seal the wound, burn wound, so that the person does not suffer from pathogenic infection. And if that management is delayed, the therapy is denied and the person suffers from drug resistance. Maybe certain drugs like methicillin will not work, vancomycin will not work in such a patient. In India also, there are many burn cases. Some of them get unreported. And if you can project the figures, you find that there is an annual mortality rate of 1 to 1.4 lakhs. Now, this issue has got a psychological component because the person who suffers from burn, he suffers from depression, scarring, disability, and lot of money goes into it. This is really a great economical burden. So if you can resolve this issue earlier, then this multi-drug resistance problem will not be there. And secondly, if you see the pattern, the burn-related deaths have come down to nearly half. If I compare the literature of 40 years, the related deaths have come down. If I see the American Burn Center data, there also there is a huge number which has to be hospitalized. And it is very important that the person is discharged from the hospital very soon. Otherwise, he or she will carry nosocomial infection. There is why we have multi-drug resistant infection, because we have lost the normal physiological barrier, that is skin. And what happens, even your immune system is affected by a burn injury. It's a thermal burn, so most of the enzymes are proteins, they also get affected. So your immune system is compromised, and those persons who are suffering from burn, they are either on ventilators or on catheters, intubated. So what happens because of this? There is chance of infection. Usually what is seen from the literature You have minor skin and soft tissue infection in the starting, 0 to 1 to 2 days. And usually you have a staphylococcus or a streptococcus infection. These organisms are gram positive. But as the time period increases, the patient is in the hospital for long period of time, he or she has severe burn or what you call third degree burn, where the total body surface area is say 60 to 70%. The person suffers from infection from gram negative bacteria. You can see the scale, and these bacteria are very harmful: Pseudomonas, E. coli, and slowly the antimicrobial resistance sets in. These are the various criteria which clinicians follow, and they find that the third scale is much better to define whether the person is suffering from sepsis or multi-drug resistance. Now, what are the various strategies in hand for management or prevention of multi-drug resistance? Some of the strategies are based on clinical practice, some are based on case studies, some are based on expert opinion. So I have tabulated them. Now, it's not possible every time the doctor visits the patient, you have to wash the hand, change the clothing, you have to have a local burn unit antibiogram. So all these precautions, all these prevention strategies can be used to prevent multi-drug resistance. And usually there are certain topical antimicrobial agents which we usually study in our lab, the silver compounds, which are finding use in antimicrobial resistance. This was a case study in one of the hospital, which I have taken from literature. Usually the females are affected by burn wound injury, and that is because of the household cooking, unsafe household cooking. Either it is a pressure cooker burst or say kerosene stove has bursted. That is the reason for burn. And the age group 16 to 25 or 26 to 35 is the most common age group we do find. And in some of the cases, we have homicide and other reasons of burning the bride that might be responsible for burn injury. And we find that the most predominant organism was methicillin-resistant Staph aureus. And the disease progression or the multi-drug resistance sets in because the person might be economically weaker background. He or she might not go in for multiple surgeries, or they may prolong the surgery time because they don't have money or funding. And that is why the multi-drug resistance sets in, and it infects the other person who is in the hospital. And this was the most common problem this I found during the COVID, the accidental flames. This is a third degree burn because of sanitizer, alcohol-based sanitizer. So the data on this is still under study. And this is coming up as a big cause during COVID-19, where sanitizer was used on large scale and people suffered a lot because of this. Thank you so much for your patient hearing. Any questions?